Welcome to today's webinar, Regenerative Orthopedics, New Treatment Options of Common Orthopedic Injuries. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Gigi Liggins, and I'm the moderator for today's webinar. This webinar is anticipated to be about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to where you can access an on-demand replay, along with a link to a short survey. Please take a moment to complete the survey. Your feedback is valuable and helps us in the planning of our educational resources. We're excited to host today's webinar and do look forward to an opportunity to partner with you. To kick us off, I would like to introduce our host, Cynthia Borbo. Cynthia Borbo is president and founder of Medical and Life Care Consulting Services, also known as MLCC, a registered nurse, a certified rehabilitation nurse, a case manager, a nurse life care planner, and a legal nurse consultant. She has worked as a nursing professional for 40 years and currently leads Medical and Life Care Consulting Services, a practice of professional nurse consultants and case managers who provide medical case management, medical legal services, including life care planning, and ancillary professional nurse consulting services. Cynthia founded Medical and Life Care Consulting Services in 2001 and is presently a member of the American Association of Nurse Life Care Planners and is a board member of the CNLCP Certification Board. She is also an active member of the Association of Rehabilitation Nurses and the Case Management Society of America. At this time, I'll pass it to Cindy Borbo.
Hi, everyone. Thank you so much for joining us again today. Before we dive into this session, I'd like to share a little bit about the Injury Insight program for those of you who aren't really aware of how we're doing this. Injury Insight is now in its 4th year, and it's a 4-part webinar series designed to educate claims professionals, HR resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments, both common and uncommon, within workers' compensation. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, and potential obstacles, and to answer your toughest of questions. If you've missed any of our prior sessions, you can access them online at www.medicalandlifecare.com or by visiting our YouTube channel. So for this year's first session, Regenerative Orthopedics, New Treatment Options of Common Orthopedic Injury, we're pleased to have Dr. Kai Mithoefer. Dr. Mithoefer is board certified in both orthopedic surgery and orthopedic sports medicine. After medical school in Germany, he received his residency training in the Harvard Orthopedic Residency Program. Following residency, Dr. Mithoefer completed a fellowship in orthopedic trauma at Harvard and the prestigious Sports Medicine and Shoulder Surgery Fellowship at the Hospital for Special Surgery in New York. Dr. Mithoefer has more than 15 years of clinical expertise and is an internationally recognized specialist for sports medicine, joint preservation, and regenerative orthopedics. His special clinical and scientific expertise includes applying state-of-the-art surgical and non-surgical regenerative technology to facilitate and accelerate return to athletics and work activities. Dr. Mithoefer has extensive experience caring for athletes at all levels, including as team physician of the New England Revolution, the U.S. National Soccer Team, World Team Tennis, U.S. Davis Cup Team, and U.S. Open Tennis Tournament, and has served as assistant medical director for Major League Soccer. Having played sports at the elite and recreational level, he understands the athlete's mindset and practices with the primary goal of returning patients safely and rapidly back to sports or work. Dr. Mithoefer has been awarded top doctor for both Castle Connolly and Boston Magazine for many years. He has published more than 100 scientific articles and book chapters and is a frequent speaker at national and international meetings. So I'd like to, at this time, have you take over, Dr. Mithoefer, and if we're lucky, his 4-year-old daughter may run into the meeting. So keep your fingers crossed. Go ahead, Dr. Mithoefer.
I can't guarantee the cameo appearance of my daughter, but we'll see what happens. Appreciate the opportunity to speak, and because this is a topic I'm very passionate about, work injuries as well as regenerative orthopedics, and combining the both is again something that's close to my heart. Work injuries, as you all know, are significant. There's about 3 million work-related injuries on average, according to the U.S. Bureau of Labor Statistics, every year, and about a third of those are musculoskeletal injuries from slips, trips, and falls, the standard things that happen, involving to a majority or a significant number of the spine, then the upper extremity, then lower extremity. But what's important is there's a significant time away from work, as well as significant direct and indirect costs associated with those. And the longer they're away from work, the more severe the injuries are. There's also more risk for disability, and that's where my interest is. And I'm coming back from a sports background, returning to sports, returning to work. Those are things I've always felt are the most important parameters that we're trying to achieve with what we're doing in terms of treatment. And I look at the workers as industrial athletes, and treat them in the same fashion as every other athlete. Next slide, please. So in terms of time away from work, as I mentioned, the musculoskeletal conditions are the number one in terms of taking people out of work for a long time. So since I've been working in regenerative orthopedics for almost 20 years, I've been implicating it more and more into the work-related musculoskeletal injuries, and with the goal of improving the outcomes from these injuries. And I want to go a little bit through that in this talk, and what options we have for some of the common orthopedic conditions, so you can get an overview of what's doable and how that can benefit. Next slide, please. So I think throughout the talk, we'll throw in a couple of slides where I'd like to poll the audience to see what your understanding is, what your feeling is about what was presented. And the first slide is basically asking you, what do you think about what regenerative orthopedics actually is? Is this something that I think this is poll number 3 that's up on the screen right now. We need to go to poll number 1. Is regenerative orthopedics something that is like a non-surgical treatment? Is it certain treatment options that are like injections, or does it involve typically just surgical procedures? Can it be both, or are you not sure? And if you could go ahead and vote, please. I think it'd be interesting to see what your overall response is. Okay, excellent. So the majority of people think that it's both surgical and non-surgical, but it's still 20% still don't know, which is obviously helpful to for the talk today. Then go ahead and next slide, please. So the definition of regenerative orthopedics is that it uses regenerative therapies to quote unquote naturally treat orthopedic conditions, utilizing autologous tissue, cells, proteins, to enhance the body's ability to heal itself and to restore the injured musculoskeletal tissue. And again, like the majority pointed out correctly, it can be non-operatively, can be injections, can be other treatment modalities, but pain relief is the goal here, facilitating tissue healing, speeding up the tissue healing, and oftentimes also can be helpful to avoid surgery. And then if surgical treatment is necessary in some of the conditions, it can help to biologically repair the injured tissue, facilitate the recovery, speed up the recovery by augmenting the surgical repair, for example, and bringing patients back to activities faster. Next slide, please. So there are multiple applications in orthopedics, and I can't go through all of them. Since I do mostly shoulder and knee, procedures, I want to focus on, those, in the majority. And next slide, please. I'm going to go through the ones you see here in the majority, but there's, multiple implications and where these technologies can be helpful. Next slide, please. So the principle is, you want to restore the joint function after an injury, and that can be, biologically enhancing the joint anatomy, restoring the natural joint anatomy, and thereby restoring function more naturally. This can be in the knee again for meniscus, cartilage, ligaments, the shoulder for rotator cuff labrum. And the goal again is to speed up the return to work, but also prevent them from developing secondary problems from the original injury, such as post-traumatic arthritis, for example. And in cases where, for example, degeneration arthritic changes have developed, or in the process, stimulating cartilage biology or reducing degradation by some of the treatment options, decreasing pain, increasing activities, avoiding disability. That's the goal of these strategies that are being applied biologically. Next slide, please. And I think I want to start with specific conditions. I want to start with knee osteoarthritis because we do see it as a result of traumatic injuries, but also from overuse in workers. It's the most common joint disorder in the United States. Arthritis basically means that the articular cartilage starts to break down at different degrees of that. It obviously increases with age, but also is very frequently seen after injuries to the joint, both in the shoulder and the knee. The developing pain from inflammation and breakdown of the joint leads to increasing disability in the joint with work activities being reduced, but also even activities of daily living as this continues. And the treatment options, even though this is such a prevalent disorder, are still relatively limited. And if you can go to the next slide, please. The traditional treatments, improve, muscle support, physical therapy, very important. I always support that. Anti-inflammatory medications are frequent cortisone injections, viscosupplementation or gel injections to help with lubrication of the joint, and then surgical procedures oftentimes as there's continued progress with arthritis. Next slide, please. And knee replacement is really the big treatment option that we have here, and hundreds of thousands of these performed in the United States every year. But they're big procedures. They have surgical risk. They're invasive. There are complications, and importantly, a long, intense rehabilitation. About 20% in multiple studies have shown that show persistent pain. The issue, particularly for younger patients who have received a joint replacement, is that they can wear out. The implants wear out. So after 15, 20 years, particularly with intense activities such as labor, you might need an additional, revision replacement. And for some of the very high demand activities, they might not be able to go back to those activities with a joint replacement. So next slide, please. There are some options with established degenerative changes to maintain the joint. And I think from a non-operative standpoint, the best two options that I think we currently have available and FDA approved are so-called platelet-rich plasma and bone marrow stem cell treatments. Platelet-rich plasma is a process where peripheral blood is drawn, then the platelets are concentrated in centrifugation, and the growth factor, where the platelets concentrate, is then injected into the joint. The platelets contain numerous growth factors that can be beneficial to the joint, and I'll go through that a little bit more in detail in a second. The second source of regenerative, biologic material that is autologous or from the patient themselves is stem cells from the bone marrow that can be aspirated from the bone marrow from different areas in the body, again, concentrated through centrifugation and then injected into the joint. Next slide, please. The mechanism of action for PRP is multiple. I think one very important thing is to understand that articular cartilage is kind of a meshwork of few little cells in there that produce proteins that then build a meshwork of different proteins that connect but also bind water, and this provides the sponge function, or the cushioning function of the articular cartilage. As cartilage breaks down from injury or from degeneration over time, these proteins in the matrix start breaking down. They don't bind as much water, and the cartilage thins, breaks down, and doesn't, absorb the shock as well. So what the growth factors from the platelets do, they actually go into this matrix, go into the cells that are kind of dormant, and kick them and say, hey, you gotta work up a little bit, and they start activating those cells to make these proteins again, which leads to a strengthening of the matrix and a bettering and improvement of the cushioning effect, thereby a reduction of the pain and improvement on function. Another important function is that the growth factors actually block certain receptors in the cells that are responsible for producing negative inflammatory mediators that can break down the articular cartilage. And the third very important factor is that the growth factors also ramp up the activity in the cells of the inner lining of the joint called the synovium, which typically make a natural lubricant called hyaluronic acid. And that lubricant is also downregulated from the degenerative process. And those growth factors go in there and ramp up the natural production, which helps with the natural lubrication, stiffness and pain associated from the loss of that. Next slide, please. So the clinical results are in level 1, meaning the highest level scientific evidence, are quite convincing, with significant reduction of pain, increase in activities, and good durability. In some cases, you can actually see a thickening of the articular cartilage again and an increase in the joint space. Comparison studies to viscosupplementation, which is a very frequently used technique, the gel injections, definitely shows that produces the PRP produces a longer but also a more pronounced response. And most importantly, there's several studies that have shown that the delay in knee replacement can be observed in up to 74% of patients with a median of about 5 years. Next slide, please. And then the next option, as I mentioned, is the stem cells from the bone marrow that gets aspirated and then injected into the joint. The cells can help here with cartilage regeneration by bringing new cellular components in that can help with structural repair. They also have secrete factors that can reduce joint inflammation, but also actively attract new other stem cells from the periphery of the joint to actually settle into the joint and help with the repair process. Next slide, please. And the clinical results are also quite convincing. A meta-analysis of more than 2,000 patients demonstrated significant reduction again in knee pain, physical function, as well as cartilage quality. This is a little bit newer than the PRP injections, but the data is increasingly convincing. Very interesting is that the use of the stem cells in comparison with PRP seems to be better, particularly with more advanced arthritis, while it's similar in patients that have lower medium severity arthritis. Next slide, please. So besides treating degeneration or symptoms, wear and tear that has established, again, the other mode of approach of treatment is treating acute conditions, and biologically restoring the joint. And I want to go through some of these examples, how to do that with regenerative options in order to facilitate recovery and return to work. Next slide, please. The first injury I want to talk about is articular cartilage injury. The articular cartilage is a cushioning tissue in the end of the bone. It's very effective at what it does, but can break down if it gets injured. You can see that on the right side, that doesn't provide good cushioning of the joint. Next slide, please. What's special about cartilage is it's very specialized tissue, and in its specialization, it's lost its ability to heal itself. So if the cartilage breaks down, it does not heal itself and gets worse and worse over time. So therefore, something needs to be done to facilitate, improvement. Next slide, please. That's important because these injuries are very frequent, and about 400,000 defects of the articular cartilage are seen every year, with about a quarter of those coming in association with ligament injuries in the joint. They're particularly seen in athletes as well as heavy laborers. Because of the high demand on the joints, the majority of them are symptomatic, and if they're not treated, they get worse over time, progressively reducing the ability to work, do sports, and development of radiographic signs of arthritis. Next slide, please. So an analogy that I like to use for these injuries is, a pothole in the street, because these are joint surface injuries. The same thing happens in the street. If you keep driving over these little holes in the street with your tire, the edges break down, get bigger, then multiple defects develop. And the same thing happens in the joint as, the progress of the breakdown happens. And that's why these cartilage defects have been shown to be a major factor for the need for knee replacement, which is about 5-fold risk for development of or need for knee replacement. Next slide, please. So what are the options? I think there are definitely some non-operative options, particularly for patients who have small defects that are not really causing a lot of symptoms, or that are not all the way down to the bone. In these patients, you can do physical therapy, activity modification, taking them out of the environment that irritates the joint. Again, viscosupplementation with gel can be helpful, as well as PRP and stem cells. Next slide, please. If that doesn't help, or if the defects are large and significantly symptomatic and traumatic, particularly, surgical treatment might be necessary. And the goal here is to, fill the pothole, and that can be done biologically with multiple methods. And I'm going to run through one of them that I think is the most effective. And you can see, why that is a good analogy overall. Next slide, please. So the technique I want to talk about is matrix-assisted chondrocyte implantation, or MACI. This is a revolutionary technique that is approved by the FDA in 2016. It's based on autologous chondrocyte transplantation, which was originally published in the New England Journal of Medicine. It's a procedure where you go into the joint first, you harvest a little piece of cartilage, then you take the cartilage to grow new cartilage outside of the joint by concentrating the cells from 20,000 cells to like 40 million cells, and those 40 million cells are then placed on a collagen scaffold, which is then shaped to the size of the defect, and then the procedure then placed back into the defect, and it allows the new cartilage to form with very good functional outcomes in both return to work as well as sport. Next slide, please. This is how this looks. This is the cartilage defect on the left upper side. Then you clean the defect out to healthy tissue margins surrounding it. You really want to have healthy tissue so the new cartilage can connect with healthy tissue, not still compromised tissue. And then the membrane is placed into the defect and then gradually heals. Next slide, please. And this is how the healing process occurs initially. You see the cells at the bottom. You see the collagen membrane mesh sitting on top of it, keeps them in place. And then the cartilage cells start getting active. They start making the proteins I was mentioning before, making that matrix. And it's almost like as the membrane then resorbs over about 6 to 8 weeks, those cells, it's like a cake rising, filling up the defect, ultimately completely to the edge of the surrounding cartilage. Next slide, please. And this, after this initial proliferative phase, when the cake rises and fills in, then there's a second remodeling or maturation phase where the cartilage has filled and then gets stronger. And part of that is a process of gradually loading it more, which allows it then to become, normal cartilage. It's similar qualities, not just volume, compared to normal cartilage. Next slide, please. So what are the functional results? The functional improvements from this technology are quite impressive. About 2/3 to almost 100% functional improvement, even in salvage procedures, 75 to 80% improvement. Best results are seen in younger patients, but even if you look at those numbers, they are overall quite impressive and homogeneous. But I think it's the most important benefit of this procedure is you don't only improve significantly, but you maintain that improvement over time, which is really the best in comparison to any other cartilage repair techniques. Next slide, please. So there are some studies that have looked at this for 15 years. The technique was available in Europe for a longer time, and there are studies from Europe which have looked at this 15 years out, and they found that very low failure rate of less than or about 50%, with less of them, requiring, for example, a joint replacement. I think their joint replacement rate was about 4%. Most importantly, as I said, the improvements that usually occur early are maintained. You see between a year and a half, 2 years out, the functional, when they're functioning top out in their function, they are maintained nicely, even over the highest demand, including work as well as sports activities. Next slide, please. And there's actually specific studies in the work comp population, up to 150 patients included with high demand occupations, and significantly large cartilage defect. 8 centimeter squares is a big cartilage defect, but again, supporting the benefit of this technique. Return to work in 100% of their reported patients, full capacity 80 to 90% almost, around 6 to 12 months, depending on what work capacity is. The importance is that there's no difference between heavy or lighter labors. So even under highest demands, this can be successful. Next slide, please. I'm excited also about new developments that we're currently working on. The technology we're working on, an arthroscopic technique, is already minimally invasive, but requires an incision. This is a new technique we're working on right now. We have a meeting again next week to optimize this, to see if we can hopefully bring this, to clinical use and further reduce recovery times and facilitate recovery to work activities. Next slide, please. So this is a case that I wanted to bring up. This is a 31-year-old firefighter, had a work-related injury, had a persistent pain and swelling that didn't respond to PT as well as other treatment modalities. He ultimately had an MRI scan, which demonstrated a large cartilage defect that you can actually see here on the right side. This is the intraoperative image. So he then went on to a MACI procedure, and this is how the membrane looks intraoperatively placed into the defect. Next slide, please. And the patient really had a good recovery, completely repaired the defect. You can see the MRI pre-op and post-operative afterwards, and you can see it has completely filled in with cartilage that has the same quality as the surrounding cartilage in terms of MRI signal. He was able to return to full work as a firefighter, as well as is now, I think, about 6 years out and continue work without any limitations, supporting again the longevity of this repair technique. Next slide, please. So I want to break things up and just wanted to bring in, because I talked about firefighters. A little fun fact, I actually was a trained firefighter before I went into a medical career. I was always fascinated with firefighters, like I was a child. Then I went into my training. It's been very helpful actually nowadays, in my medical career, because I can appreciate demands under heavy labor, under stressful conditions at work, and particularly with firefighters, who I see not infrequently. And this has really helped me be a better physician, be better in, again, safely and gradually bringing patients with significant demands in their joints back to what they love doing, which is what most firefighters, as I experienced, really are passionate about their work. Next slide, please. So I want to move on to meniscus injury. Meniscus injuries are very frequent. They are little shock absorbers that sit between the joint surfaces, and when they tear, that can cause mechanical symptoms. So you can see that little, flipped fragment that you see on the right side that can certainly produce problems. Next slide, please. The meniscus is frequently injured. Treatment can be surgical or non-surgical. Importantly, if surgery is done and the meniscus is removed, that oftentimes leads to arthritis down the road. So preserving the meniscus is very important to preserve function on short term, but also long term. Next slide, please. And there are different options from a regenerative biological standpoint to preserve the meniscus. Non-operatively, we have the option, for example, with degenerative tears, to do targeted PRP injections, and they have been shown to reduce the need for surgical intervention by about 72%, which then helps to maintain more of the shock absorber in the joint, which can be helpful long term. And if surgical meniscal repair is performed, which is particularly for traumatic tears, oftentimes recommended, this can lead to a 50% reduction of arthritic changes. Some of these repairs can fail, but with PRP augmentation during the repair, this failure rate can be significantly reduced by the addition of the biologic adjunct of PRP. Next slide, please. Another very special area in meniscal injuries is the so-called meniscal root injury. It's an increasingly recognized subtype of meniscal injuries. The meniscal root is the attachment point of that kind of C-shaped meniscus to the bone. There's one in the front and the back of the knee. What happens when these attachment points are lost or torn is that the meniscus shifts outside of the joint and extruded, which biomechanically leads to a loading pattern that is similar to as if the meniscus had been completely removed. And that's been shown to be critical because it can facilitate a rapid progression to osteoarthritis and is associated with more than 100-fold increased risk for knee replacement. Next slide, please. And this is an example of a patient that I saw as a worker that was injured about 2.5 years before I saw him, was diagnosed with a meniscus tear, particularly meniscal root tear, was treated conservatively because oftentimes the meniscus, because it gets pushed outside of the joint, doesn't catch or doesn't cause locking in the joint. So he was treated conservatively, and then I saw him, 2.5 years later when he had to advance degenerative changes in the inside compartment, as you can see here, which really limited the options of what we can do. And next slide, please. The meniscal root repair is really a fantastic operation that is, really effective at all ages, even with mild to moderate arthritic changes already established. It can be helpful both for acute and chronic tears, but the earlier the better, of course. Importantly, the outcomes are really quite impressive with a reduced rate for osteoarthritis, as well as a requirement for total joint replacement at 10 years, significantly reduced. Key here is, again, early diagnosis and repair, for critically for joint preservation to avoid what we just saw in the previous slide. And that's why sometimes getting an MRI, if there's a suspicion for that, is important. And I know we oftentimes kind of try to delay that until PT has failed or other things have failed. In some cases, or oftentimes, particularly in these cases, picking this up earlier can be extremely important. Next slide, please. I want to move on to ligament injuries in the joint, and I think the most commonly injured ligament is the ACL. I'm sure you're familiar with injuries to the ACL from athletes as well as from patients that you've worked with. Next slide, please. So the ACL tears don't heal or repair. That's kind of the typical dogma that we were working with in orthopedics, because people have tried it in the past, it didn't work. But the problem is ACL injury produces instability in the knee, which clearly interferes with the ability to work, particularly in heavy labor. But is also associated with secondary injuries such as meniscal tears, because the meniscus picks up as a secondary stabilizer. It's not made to that and then actually wears out. And then also cartilage defects, which are hard to fix if they're developed. So their question is, are there some regenerative options for the ACL? And next slide, please. I think it's important to look for options because, again, as I pointed out, it's very frequent. There's post-traumatic arthritis that can develop. But standard treatment has always been ACL reconstruction, where a tendon is kind of placed in the position of the ACL. There are various graft options that you can use, but there's some downsides to it. And there's still a noticeable, failure and re-injury rate. And I want to kind of go on to the next slide and ask a quick question in a poll again. If I talk about ACL reconstruction versus an ACL repair, do you kind of know or kind of have understand what the difference between the two is? I appreciate you just clicking on that pretty quickly. And these terms are used, very overlappingly, even by orthopedic surgeons. So I think it's important to understand the difference, and I want to discuss that with you. Let's see what the results are. Okay, great. Perfect. So you understand the difference. Then we can move on to the next slide. But 1/3, hopefully I can help improving your understanding. So as I mentioned before in the slide before, ACL reconstruction means you place a tendon graft in the position of the ligament that's torn. ACL repair means you actually preserving the ligament and repairing it, and it has multiple benefits, as I'm going to point out. And there's two different techniques how to do that. There's a so-called ACL Premary Repair, and there's a so-called bridge-enhanced ACL repair or BEAR technique, which we might have heard of. Next slide, please. So the advantages of repair versus reconstruction are that the repair is anatomic. There's two separate bundles, which I'm going to point out in a separate slide. The proprioception is maintained with this technique. It's overall less invasive. It's less painful. There's no deficits from taking a tendon in different parts of the joint or around the joint, which can leave morbidity in terms of persistent postoperative pain, but also persistent muscle function from taking tendon grafts. And it overall feels like a more natural knee function afterwards for most patients. And there's often an accelerated recovery from repair versus reconstruction because of these reasons. Next slide, please. So the normal ACL, which is very specific but important, has and two bundles. One is important for the movement back and forth in the knee, and that's where most of the instability comes from. And then there's also an important second bundle, the posterolateral bundle, which is important for the rotational stability of the joint. And the reconstruction technique with a single tendon really just reconstructs the anteromedial bundle and the back and forth stability, but not the rotational stability, and that can have negative effects on the overall knee function. Next slide, please. The second thing is the proprioception. Proprioception is actually a deep joint sense. This is important because the joint requires that kind of feedback to function normally. And these sensors, there's multiple sensors or little tiny sensors that are at all levels of the ligament itself that kind of provide a feedback. So if there's a stress, for example, there's a mechanical stress on the ligament, that kind of sends a signal to the spine, and then as a reflex, the muscle activation starts that protects the ACL. So that obviously is lost when the ACL ligament is removed when you do a reconstruction, but this is maintained and very important if an ACL is repaired because you maintain these little nerve sensors. Next slide, please. The ACL Premary Repair is a technology that basically is used for relatively intact ACLs that are kind of pulled off the femoral part, and that it reinserts that back and reattaches it where it was pulled off from. And you can see the difference to the graft seen in the other slide. Next slide, please. These, unfortunately, are limited to certain types of ligament tears only that are still very close to the attachment point on the femur. These, in some studies, are up to 43% of the tears. In my experience, that's a little bit less. Next slide, please. And this is how this looks intraoperatively. You have the ligament that's torn, but a long portion of the ligament is still intact. You're running the sutures through it and then reattach it with the anchors into the bone. And then the additional kind of suture that you see, it's called an internal brace. That's a suture augmentation device that you can place in there that kind of stabilizes the joint or helps to stabilize the joint immediately while the ligament heals back to its insertion point and facilitates recovery in these patients. Next slide, please. Clinical results on these are up to 5 years out now with very low failure rate, high activity return to activities, particularly sports. Internal brace does reduce the failure rate. In younger patients, because they're oftentimes not following the rehabilitation protocols, there's a higher re-injury rate versus, in older patients, essentially all of them will do well without having an additional tear. Next slide, please. Want to move on to the so-called BEAR technique, the Bridge Enhanced ACL Restoration. This is a technology that uses a implant that is placed between the tear ends of the ligament that are filled with or saturated with blood to bring in some of the regenerative components, cells, and growth factors to then help bridge and heal the defect in the ligament. Next slide, please. And again, in comparison to the primary repair, you can use these anywhere with tears that are high, middle, or lower in the ACL. So this is really something that is quite flexible to use. Next slide, please. And again, the principle here in terms of understanding why ACL repair hasn't worked traditionally is that the joint fluid contains certain components, including plasmin, which breaks down the clot that wants to form between the ends of the ligament, and therefore prevents the reconnection. And that's why the spontaneous healing doesn't work. The same thing happens if you just suture the ligament, which has been done in the past. But again, there's exposure to that joint fluid. In contrast with the BEAR implant, it's sutured, around or placed around the ends of the torn ligament. So it really provides a kind of a sealed off conduit where the growth factors from the blood that were injected into it, as well as the cells, can then migrate into the defect and then produce collagen, bridge the defect, and then ultimately lead to healing of the ligament. Next slide, please. And this is really a gradual but continuous process over several months. And there's also maturation there. You can see how it gets thicker on the MRI over time. In majority of cases, if you compare the repaired ligament to the opposite side, if it's normal, it actually tends to be thicker from the repair, even stronger than a normal ligament. Next slide, please. So the clinical results are very similar to what we can achieve with ligament reconstruction in terms of functional outcome scores, stability testing, as well as functional testing with hop testing, for example. Muscle recovery tends to be better because, again, you're not robbing Peter to pay Paul and take things away from the joint that support it, such as hamstrings, for example. There's an 86% return to demanding activities, usually between 6 to 12 months. A lower rate of contralateral re-injuries with a similar re-tear rate compared to the normal or standard, technique, ACL reconstruction. Next slide, please. And this is an example where that kind of was a groundbreaking experience for me. I was a little bit critical of this technique first, wasn't sure if that's really going to work because it was against the dogma of the ACL not healing. But then I had a patient that was 7 months out after the Baer procedure, had a car accident, had injured the knee. I had to go back into the knee to trim off a meniscal fragment. And then I was able to look at the ligament. As you can see on the images, if you compare this to the left upper corner of the normal ligament, there's really a very similar appearance. And I'm probing it intraoperatively was quite stable. So that converted me and convinced me that this is really a technique that works. Next slide, please. So I want to briefly bring a case also. As a 26-year-old camp counselor that I saw in the office, had twisted the knee at work, tore the ACL, complete ACL tear, went through the Baer surgery. And this, you can see the implant as it's getting saturated with blood, and then it's through a small incision. This is inserted into the joint. He was able to return to limited duty at 2 months and return to full duty at 5 months. So quite successful, and he has been continuing to do well. Next slide, please. And this is how follow-up MRIs in his case looked. Preoperative, the tear of the ACL, then the nice thickened and a reinforced ligament about a year afterwards. And this really works well. And similarly, the primary repair option, I had actually a patient that I saw earlier this week who had a multi-ligament injury where I did a primary repair where I reinserted the ligament and also did a reconstruction or a repair of the medial collateral ligament. And the patient returned to work, light duty at 6 weeks, which is essentially unheard for multi-ligaments, and then returned to full activities. I actually allowed her to go back on Monday when I saw her, and that's only 3 months out from her surgery. So you can see that the benefit in terms of moving the joint faster, allowing less pain, less swelling postoperatively to move faster, and then progress through the stages of rehabilitation a little bit quicker. Next slide, please. So I want to show a little video because I think that the benefits of the Baer has been increasingly been recognized. So go ahead, please. We have the sound.
ACL in their knees every year, and many undergo ACL reconstruction.
But there may be a more natural and less painful way to fix it. WBZ's Dr. Malika Marshall shows us the new treatment which could help patients avoid traditional surgery.
Tori Waldstein was hitting the slopes with friends a few years ago when she went tumbling over a bump.
My ski didn't pop off, so my knee sort of twisted around, and I knew pretty quickly something bad had happened.
The 30-year-old had suffered a tear of her ACL, a ligament that connects the thigh bone to the shin bone and helps stabilize the knee joint.
It happened pretty frequently, particularly in patients who are very active, like Tori. Typically in pivoting cutting sports like soccer, basketball, football, and skiing.
Dr. Kai Mithoefer is an orthopedic surgeon at New England Baptist Hospital. He says most patients who need surgery undergo a traditional reconstruction, where the torn ligament is replaced with a tendon removed from another part of the body, like the quadriceps or hamstring muscles. But that can lead to chronic pain and weakness in those areas.
You're robbing Peter to pay Paul.
But a new procedure called Bridge-Enhanced ACL Restoration, or BARE, avoids that.
What the technology does, it actually helps to biologically heal the body to heal itself.
This collagen implant is first saturated with the patient's own blood to provide growth factors to aid in healing, and is then placed between the stump ends of the torn ligament. Compared to a traditional ACL reconstruction, patients who undergo the Bear procedure spend less time in the OR, have fewer incisions, less post-op pain, and are up and about much faster.
It's also a more natural biologic restoration of the joint anatomy, joint function, which I think restores function and ability to return to activities more naturally.
Tori chose the Bear procedure over traditional surgery and is happy with the results.
I'm back to doing pretty much everything I was doing before.
She was back on the ski slopes the very next season. Dr. Malika Marshall, WBZ News.
The next slide, please. Yeah, so I think that gave you a little bit overview over the technology, which is really, I think, a nice natural way of preserving the joint. It doesn't, it isn't something just that we can apply to the knee joint. I've showed you several examples, in the knee, but there's multiple, applications in other joints. I want to briefly talk a little bit about the shoulder as well, because that's very frequently injured area as well. If you can go to the next slide, please. So rotator cuff tears in particular, I'm sure you all seen rotator cuff tears, which is very frequently injured, where the connection between the rotator cuff, which is 4 muscles that move and rotate the shoulder and control the shoulder movement, are torn and disconnected from the bone and associate with pain and weakness in the shoulder. Next slide, please. This is, as you know, one of the most frequent orthopedic work injuries. It is obviously associated with significant work limitations, but also if it remains repaired for a long time, can lead to secondary arthritic changes. Can happen both chronically from repetitive use, but also from acute trauma, from injuries, from falling, etc. Best results, and I think that's really important, are with smaller tears and when the early treatment is applied. Unfortunately, because of presentation, because of delays in terms of obtaining studies, etc., it can be a while until you know about these injuries, and then sometimes the tear size is bigger, and it's been shown consistently that bigger tear size or higher time to treatment has definitely a negative outcome effect. Because the tendon tear when it's not attached, the tendon will retract. It's like a spring that recoils and forms a bigger gap that then is hard to bridge again. And also the tendon atrophy develops where the tendon gets replaced sometimes by fatty tissue, but also gets much thinner, also then leading to increased failure rate and less favorable outcomes. And there's, because of the importance of this technology, regenerative orthopedics has become an important part of dealing with these procedures and injuries. Next slide, please. So rotator cuff augmentation can happen in different ways. It can happen for partial tears as well as full tears. It can happen surgically or without surgery. And it can be to augment the rotator cuff, from a structural standpoint, also from a cellular standpoint. Next slide, please. So the non-surgical options are, PRP again. I think PRP is really, really helpful if it can be injected under ultrasound guidance in the area of the partial tearing that you can visualize with the ultrasound and inject it into the area. That can result in, bringing in cells through a chemoprotective effect from the growth factors to come in, help with neovascularization, but also collagen deposition in the area, and therefore actually a structural healing process. In comparison, and that's not only healing the defect, but also really significantly improves pain. In comparison, studies with cortisone injections have been shown significantly better work than a cortisone injection. And importantly, some of the side effects of cortisone can be avoided. For example, the increase in blood sugar that can, make it not a good option, for example, in diabetic patients. Next slide, please. So if full tear is there, or if partial tears are there and they haven't responded to conservative treatment, then a rotator cuff repair is important to do, and structural augmentation can be done both for partial as well as full rotator cuff tears by using a bioinductive collagen membrane that has capacity to not only structurally thicken the tissue by about 2 millimeters at least, which increases the strength, but also induces, again, cell growth into the area where the thinning was in the rotator cuff there, and further biologically enhancing their healing process. This can be significant in terms of accelerating rehabilitation, letting people move earlier because the tendon is stronger, it's less likely to re-tear again. And it has, in fact, been shown in randomized controlled studies to reduce the risk for re-tears by about 86%, which is really quite important and significant for returning patients back is one thing, but keeping them and allowing them to continue work under sometimes stressful activities at work. This is where the big benefit comes from, for example, the work population. Next slide, please. And similarly, we can use cellular augmentation. As I said, the tendon atrophy can involve replacement of some of the tendon and muscle cells. And if we use bone marrow stem cells, again, and inject that into the repaired area, form a little clot on top of the defect, this can actually improve both the quality from a cellular standpoint, and also the quantity by, again, collagen deposition and strengthening through the effect of those cells in the area of the rotator cuff repair. And this, again, has been shown to improve the scores on follow-up MRIs, meaning it's a better repair, and that translates, again, in better function, and importantly, lower re-tear rates by about a third of what you find without the augmentation. Next slide, please. So as you can see, in summary, the regenerative orthopedics is, an actively evolving orthopedic field. There's a lot of new biologic therapies that are in evolution right now, but some are definitely established. They can help with more anatomic and more biologic injury repair. They can improve outcomes, accelerate recovery, and improve the return to work, reduce the re-injury rate, which I just showed, particularly for the rotator cuff. And then also lead to more natural joint preservation by reducing risk for joint problems down the road. If you have an ACL tear and you repair the ligament, the chance of having arthritis down the road tends to be a little bit lower. So short-term and long-term benefits from this. Next slide, please. I want to quickly again go back to try another poll. So after listening to this, do you think that orthopedic treatments are, have a role or can be helpful in improving outcomes from work-related injuries? See the results. Oh, well, okay, good. So I guess I was successful in explaining some of the benefits from it. So I appreciate the response. Next slide, please. So a couple of announcements I wanted to do before I finish. I'm sure you might have heard of Boston Sports and Shoulder Center, which is the group that I'm currently a member of. We used to be, just really sports medicine and shoulder specialists, but we have grown over the last 2 or 3 years, incorporated and brought in specialists from all kinds of, subspecialties of orthopedics. So we're really not just sports and shoulder specialists anymore. We really cover everything. And as actually of May 1st, we're going to change our name. We're going to become Boston Bone and Joint Institute. As part of the BBJI, we're going to have subspecialty center for every subspecialty. And we're also going to have a specialty center for regenerative orthopedics as well as for orthopedic work injury, because we understand that these patients do need special care, needs an infrastructure that can help them work through the process of the injury, but also reintegration. And communication is a big part of that injury center besides the medical treatment. Next slide, please. As part of our dedication to orthopedic work injuries, we also have a orthopedic work injury conference, which you might have been to in the past. Last year, we started having it at Waltham Woods Conference Center. We're going to have it again in this October, on October 11th. Hope we can save the date and participate and come to that, so we can continue to work together and build, an education, not just of what I just told you, but maybe also all the other areas of orthopedics that we're representing now. Next slide, please. Thank you very much again for inviting me to give this webinar. If you have any questions, concerns about this topic, you can go either to my website or you can send me emails. I'm always very happy and approachable. I like communication, direct communication, and solving things quickly and directly. That I think is very helpful for dealing with any patient, but particularly I think in the work space, I think that really helps avoiding delays. With avoiding delays, I think the patients stay socially engaged with their workplace, and that I think is a huge factor in returning them back to their work activities. So I'm always happy to communicate. Please reach out to me for any concerns with or without patients. I'm happy to communicate at all times. So thanks again for giving me the opportunity.
Much. Yes, thank you, Dr. Mithoefer. This was awesome. This was a really fantastic presentation. We do have time for a few questions, so go ahead, please, and submit your questions. And in the meantime, I'll get started with some of those that we've already received. So the first question is, do you feel getting treatment approval difficult through insurances? Is it getting easier for these regenerative orthopedic options?
Yeah, it's definitely getting easier. Some of them are approved, some of them are not approved. Depends on what we're looking at. You know, for example, the Bear procedure is gets approved. Frequently, the primary ACL repair is approved. The collagen augmentation oftentimes gets approved for the rotator cuff. Meniscal repair definitely is approved. PRP depends a little bit. Most of the time, it's not approved, even though there's really high level, randomized controlled studies showing that it's beneficial. But there's I think a process of gaining more and more scientific data to show the benefit. I think PRP was originally used many years ago and overused, and I think without having good scientific data, then its reputation wasn't as good anymore, and insurance companies took back some initial improvements or approvals that they had. But now as really solid scientific studies are coming out more and more, I think it's just a matter of time when they kind of get improved more. And again, in work-related cases, it really has been very positive. I've been communicating with adjusters or patients about this, and there's case managers, and have been very positive support of these in the work population, because again, we're trying to speed up the process. We're trying to bring them back faster, and as you saw from the presentation, there's a clear benefit from those technologies.
Fantastic. And it sounds like, are you seeing this not just in workers' compensation, but in all health insurances?
Yes.
Okay, awesome. Second question, are there age limits to when these types of procedures can be done?
Yeah, great question. Not really. I think it depends a little bit on the indication or the specific diagnosis that you're dealing with. But, for example, rotator cuff tears, ACL tears, meniscal tears, cartilage defects, I think they can all get used. I think the cartilage replacement, like the chondrocyte transplantation, the MACI procedure, I think usually if you get to 50, 55 years old, then insurance companies or regular insurance companies say, well, would you consider a joint replacement? And I think that's kind of a transition zone that can always be discussed depending on the activity level and the biologic age of the patient. But I think for most of the technologies, I would say they can be applied through a broad spectrum of age.
Okay, thank you. I have one more question, and then I'm also going to go ahead and shift to the next slide. In the upper right-hand corner, there's a QR code. If you could just scan that with your cell phone, you can take our survey on this session. And then there's a preview of what's coming up in June. But final question to Dr. Mithoefer is, how long does it take PRP and partial rotator cuff tears to be effective? And then how long do you restrict patients from activity before return to work?
Yeah, good question. It depends a little bit how long they've been having symptoms and how big the tear is, which muscle is involved. But on average, they get an injection for 2 weeks or so. I really don't want them to do anything. And then at that point, they start, gradually with PT again. Usually at 6 weeks, we try to see how they're doing functionally and then start reintegrating them into light duty. And then hopefully by 3 months or so, full duty. But again, it depends a little bit on which location it is, what muscle is involved. But usually that's kind of the general timeline.
One more question. How many PRPs are needed?
needed, again, you can repair things without PRP, but as you saw, there is definite benefits from it. So my approach is always, if, as I said, return to sport, return to, and I do this to a lot of my athletes as well, return to work is important. And as I mentioned, I think that the biggest, in my experience, the biggest factor of failing to get people back is leaving them out. So leaving out of work, they get disengaged. If we can do something to see them, they're making quick progress, they're getting re-engaged quicker, they're going back to light duty quicker, I think that makes a huge difference. And there is always costs attached to these but I think they would pay off very quickly if you just return the patient back more quickly. I think
if I could just go on with that. So let's say you do one PRP injection and then you wait a period of time. Would you repeat that again and do another PRP? Possibly?
Yeah, it's a great question. Depends on what the result was. Typically I wait for 3 months, and by then you see how much benefit you had. In some patients, you can have a partial response, but they're not completely recovered. Then you can repeat it. That can happen, for example, in cartilage repair patients or cartilage injury patients. That can be the case. And then you can do a booster shot at 3 months, and that can lift them up to the level where they want to be and can be fully functional.
Perfect. Thank you.
All right, folks, we don't have time for any more questions. We want to honor the commitment here. So we just want to say thank you for joining our first Injury Insight of 2024. A playback of this webinar will be available within 48 to 72 hours. And finally, I do ask that you take the time to complete the survey by scanning the QR code. And then additionally, there's a post email that goes out, which will also have a link to the survey. And finally, just a great thank you again to Dr. Mithoefer for sharing such great information about regenerative orthopedics. We hope to see you at our next session. And if you want to take a look at all the others that we've hosted in over the last 3 years, you can visit us online at www.medicalandlifecareconsulting.com. All right, that's it for now. Thank you.
Thank you, Dr. Mithoefer.
Thank you very much.
Thank you.